Oh. Okay. The വലിയ കുഴപ്പം തോന്നിയില്ല because she is passing adequate urine. Cardiac function is reasonably all right. ഞാൻ നാളെ ഞാനിപ്പോ ഫൈൻഡ് ഔട്ട് ഒരു 9 മണിയാകുമ്പോൾ ചോദിച്ച് മനസ്സിലാക്കാം എന്തെങ്കിലും പ്രത്യേക നിങ്ങൾ മാറ്റാനായിട്ട് പ്രത്യേക കാരണം ഉണ്ടായോ എന്ന് ചോദിച്ച് മനസ്സിലാക്കുന്നത്. ഐ ഫൈൻഡ് ഔട്ട്. ശരി. Yeah, only 3 students have logged in. Once we have about 8 or 10 students, we will start the discussion.
Sure, sir.
Okay, I think we'll start the discussion. We have got about 6-7. We'll wait more. Maybe we can wait another 5 minutes and then we'll start the discussion. Okay, we shall start the discussion. Eknath, would you like to discuss the case?
Yes, sir, I will discuss.
Okay. So I will share the screen. Okay, right. We can start the discussion.
53. Shall I read, sir?
Yeah, you read. Then we'll start the discussion. Yes, please.
Okay, sir. A 53 years old male came with complaint of the exertional palpitation since last 40 years. The exertional breathlessness since 30 years. Increased symptoms is last 20 years. He underwent a wall repair 20 years ago. planned radio surgery 6 years ago. Surgery not done due to the high risk. He was advised continue on medical management, and he was stable till he developed recent symptoms. Increased breathlessness again since last 1 week. 1 episode of nocturnal breathlessness 5 days ago. Pedal edema since 1 week.
Okay. By listening to the presenting complaints, what are the conclusions that you can draw?
Just a palpitations.
What does the palpitation mean? Exertional palpitation is the initial symptom. So what does that mean?
Maybe some valvular pathology patient having some.
So volume overload. Don't go to
volume overload.
Volume overload condition. Volume overload conditions are, which are the volume overload conditions?
So in valvular, sir, we can get mitral regurgitation, aortic regurgitation.
Regurgitation. Or even
Yeah.
pulmonary regurgitation or tricuspid regurgitation. All these are all volume overload conditions. Valvular lesions. What is other group?
Other group is shunt lesions, sir.
Shunt lesion. Shunt lesion is another group of patients who may present with palpitation as the initial symptom, especially when there is a good volume overload. Okay, so that is 40 years ago. So what was his age at that time?
30. He was 13 years of age.
13 years of age. So what are the conditions that you should suspect? 13 years old boy coming with a palpitation history, and what may be the etiology?
It could be, sir, aortic.
Etiology.
Maybe rheumatic. It may be rheumatic patient. Rheumatic present with the regurgitant lesions.
Yes, a 13-year-old boy may be presenting with a
congenital, maybe congenital like bicuspid aortic valve.
Yes, congenital bicuspid aortic valve also can
but
be.
Mostly bicuspid present with stenosis, but also present with the regurgitant.
Yeah, the bicuspid aortic valve usually presents with stenotic lesions. But they can also have regurgitation. What is the pattern of stenosis and regurgitation in congenital aortic valve abnormality? The usual pattern is that as the number of cusps increases, the lesion becomes more and more regurgitant lesion. And as the number of cusps decrease, it becomes more and more stenotic lesion. So in a univalvular aortic valve, it can be purely aortic stenosis. And in bicuspid aortic valve, it will be usually more stenosis and some degree of regurgitation is possible. But there is a small percentage of patients where there can be severe regurgitation also. Third is tricuspid abnormal aortic valve, but trileaflet. They will have more significant aortic regurgitation compared to aortic stenosis. And when it becomes a quadricuspid, it must almost always it is purely aortic regurgitation. So as the number of cusps increase, there is an increase in the possibility of aortic regurgitation. As the number of cusps come down, it will be more likely to be aortic stenosis. Okay, so it can be a congenital problem. It can be or it can be AST also. Sometimes patients with AST can present with the exertional palpitation at 13 years of age. Especially when the AST is associated with the ostium primer type of AST, where there is associated mitral regurgitation. They can have palpitation as an important symptom. Okay. Then they started developing exertional breathlessness, 30 years. What does that mean?
Patient started exertional breathlessness at 30 years.
Interpretation.
So it could be due to hypertrophy.
Yes, it could be due to some degree of
some diastolic dysfunction.
Diastolic, or it could be even systolic or diastolic malfunction, LV malfunction, resulting in some degree of pulmonary congestion and resulting in the symptom of exertional breathlessness. Okay, so he underwent a valve repair. So obviously this is a
valvular lesion.
And when somebody has undergone a valve repair, which valve is more likely to be repaired?
Mitral valves.
Mitral valves mostly.
So its mitral valve is more often repaired than the other valves. So looking at the story, somebody who underwent a valve repair 20 years ago you must think that patient must be having a mitral valve repair, and the lesion for which he underwent mitral repair is mitral regurgitation. What are the different? Which is the lesion which is most suitable for mitral valve repair? Which is the lesion which is most suitable for repair? Which is the mitral valve lesion which is most suitable for mitral valve repair?
Regurgitant lesion.
Yeah, regurgitant lesion. I'm asking, are you looking at the etiology? Is it rheumatic? What are the different causes of mitral regurgitation? Etiology of mitral regurgitation.
Rheumatic. One is the rheumatic, sir.
Rheumatic.
Second is mitral valve prolapse.
Mitral prolapse.
Then it may be due to immediately after acute mitral regurgitation, due to the myocardial infarction.
Okay. Following myocardial infarction, they get a mitral regurgitation. Yes.
Post BMV patient get a mitral regurgitation.
Post balloon valvular. Yes. What else?
Sir, associated ASD with
yes, congenital. There is not a echo. Hello, Prayag. Why is this? Why there is a lot of echo? Are you there, Prayag?
Yes, sir, I am here.
What is the reason why there is a lot of echo?
I think the named as it faced the echo issues, sir.
Eh? Hello.
Hello.
Now it's better. Okay.
Sir, actually, the name as guy in this group, when he turn it on mic, so at that time the echo issue is coming.
Usually echo happens either maybe some problem in the technical side, or it may be because if people are using simultaneously two axes.
Yeah.
That can result in echo, because one sound from one location can get transmitted to other location and can give rise to an echo. Anyway, now it is not there. Okay, right.
Okay.
So few causes of etiology of mitral regurgitation. You said it is rheumatic. You said it can be mitral prolapse, or it can be following myocardial infarction, or it can be congenital, like sometimes a parachute mitral valve, or sometimes it can be associated with other lesions like ostium primum ASD. And what are the other causes of mitral regurgitation? Post-operative patients following balloon valvuloplasty. Okay, what else?
ischemic MR, sir, dilated
Functional.
dilated
cardiomyopathy. Patients who have got LV dysfunction, they can have mitral regurgitation. Yes. Trauma. So sometimes trauma can result in avulsion of the mitral leaflets, can give rise to mitral regurgitation. Yes.
Infective endocarditis.
Infective endocarditis, very good.
Carcinoid syndrome.
Which one? Carcinoid. When does the carcinoid give rise to mitral regurgitation?
So pulmonary carcinoid.
Yeah.
Pulmonary carcinoid.
If there are secondaries and there is a pulmonary carcinoid, that can result in mitral regurgitation. Yes. What else? Mitral regurgitation. Any other reason for patient develop mitral regurgitation?
HOCM.
HOCM, very good. Patients with HOCM may be associated with mitral regurgitation. Rheumatoid arthritis, we already mentioned. SLE, rheumatoid arthritis, all can give rise to mitral regurgitation. So when you look at mitral regurgitation, you can classify into two categories. One, due to valvular pathology, and due to myocardial pathology, like myocardial infarction, dilated cardiomyopathy. It can happen in endomyocardial fibrosis, So there are a number of conditions where a myocardial involvement can result in mitral regurgitation, and there are other conditions where the purely a valve involvement can result in mitral regurgitation. Of these, which one is the most suitable for mitral valve repair? Eknath?
Rheumatic.
Rheumatic is not the most ideal. People do repair of the rheumatic, but most ideal is mitral valve prolapse, especially the prolapse of the middle scallop. Even the posterior leaflet, if the middle scallop is the one which is prolapsing, and that is the one which the surgeon can, without much difficulty, subject the patient for a mitral valve repair. So all mitral valve prolapse or mitral regurgitation patients, the surgeon should always try to see whether valve can be repaired or not. But of the various etiologies, the most ideal is mitral valve prolapse with a middle scallop prolapse. That is the best one for repair, mitral valve repair. So this patient underwent a valve repair, and the most frequently repaired valve is mitral valve. So we will consider that this patient had mitral regurgitation and is undergone a mitral valve repair. Okay, right. Yes. Then the surgery was redo surgery was planned. So what is the reason?
Stenosis.
Yes, there is a possibility that the valve might have undergone stenosis, or it also possible that the surgical repair was ineffective, and the patient might have had the regurgital lesion, and that might have progressed, and the patient was advised to redo surgery. Surgery not done due to high risk. What is the most important point which increases the risk for any surgical intervention? What is the most important single point in which, whatever may be the condition that you are operating upon?
Maybe LV dysfunction, sir.
Very good, LV dysfunction. LV, the ventricular dysfunction is the most important single point where the surgical risk significantly goes. So the patient did not, the patient did not undergo surgical procedure because of the high risk. Obviously means that the patient might have developed significant degree of LV dysfunction also. We can't be certain, but we are drawing conclusions that way. Do we have evidence that patient might have developed LV dysfunction in the subsequent story?
Sir, they increase breathlessness also.
Yes.
Pedal edema, PND, and yes, sir.
Yes, the patient
PND is there, and pedal edema is also there.
Yes, sir. The patient has developed increase in breathlessness. He had a paroxysmal nocturnal dyspnea, and also has developed features of right heart failure, pedal edema, indicating that all our conclusions that the patient might have had LV dysfunction is correct. So from the symptoms of the patient, Eknath, what is your conclusion?
Sir, actually, it's a valvular. Is actually it's a regurgitant, mitral regurgitation. So
The patient has got a volume overload, most likely.
Volume overload.
Regurgitation. And the valve is
mitral valve.
Mitral valve. Okay, right.
Mitral valve.
Patient underwent a surgical treatment.
Then patient underwent the repair, and again patient became symptomatic.
Most likely, patient the repair was not effective.
Not effective.
The residual regurgitant lesion which progressed, and the patient is now presented with
shortness of breath, PND, and right-sided heart failure.
Okay, right. Yes. Okay. Any other somebody would like to discuss any additional point? Okay, then we'll go to the rest of the story, and then we'll discuss subsequently. Okay. Okay, right. Yes.
Sir, history of present illness. His symptom dates back to the 40 years when he started experiencing exertional palpitations while playing with the classmate at school. Regular palpitations then settles on the taking the rest. No other associated symptoms like the breathlessness, chest pain, fatigue, or the syncope. He was taken to the doctor, who said that he has a wall leak and may require the wall surgery at the later date. He advised to take a penicillin injection once in 3 weeks.
So what was the diagnosis of the doctor?
Rheumatic heart.
Yeah, so the doctor might have thought that it is a rheumatic heart disease. Since we are thinking of a volume overload, most likely it must be mitral regurgitation. What is the commonest valve involved in rheumatic heart disease?
Mitral valve.
Mitral valve.
Mitral valve. In acute rheumatic fever, mitral regurgitation is almost 100%.
Yes,
In
sir.
about 20% of patients, there can be associated aortic valve involvement also. Aortic valve involvement is more frequent when older children are affected. When the child involvement is younger, below the age of 5, 6, or even up to 10, mostly it is the mitral valve which is involved. And as the child grows older and older, the 15 or around 12 to 15, the possibility of aortic valve involvement gradually becomes more. So mitral valve involvement is the most frequent valve involved. The lesion is mitral regurgitation. A small percentage of patients can have aortic valve involvement in the form of aortic regurgitation. Okay. During the acute phase of rheumatic fever, other valve lesions, especially the tricuspid and pulmonary valve involvements, are not that common, or rather it is not detected. But these some of these patients with rheumatic heart disease can have both the valve involvement, all the 4 valve involvement, as in the order of frequency: mitral valve, aortic valve, tricuspid valve, and pulmonary valve. So here the doctor thought that the patient is having rheumatic heart disease, and that is why he has advised penicillin injection once in 3 weeks. Okay, right, go ahead.
About 30 years ago, he started developing the exertional breathlessness class 2 symptoms.
Class
got,
2 no, define class 2.
Heart disease is there, sir,
Oh.
and patient patient gets symptoms.
The symptoms on ordinary physical activity.
Yes, at ordinary physical activity.
Yes, the
But
definition
palpitation,
class 2 is a patient who has got, of course, he has got a heart disease, who is having mild symptoms. He is symptomatic on normal routine activities, and the symptoms considered are
palpitations, fatigue, syncope, and chest pain,
and cardiac pain. Okay, right. Yes. So he is class 2 symptoms. Okay, go ahead.
He got married at the age of 26 years, 28 years ago, and could have a normal sexual relationship with the his spouse. About 20 years ago, his symptoms deteriorated to NOHA class 3.
What is
He
class
was
3?
advised
Define class 3.
Less than the ordinary physical activities.
No, that is not enough. You have to define it correctly. Anybody?
Sir, in presence of heart disease, there are symptoms at less than ordinary physical activity.
Not complete. See, the class 3 is a patient who has got moderate symptoms. That's the definition. Well, class 3 is a patient who has got moderate symptoms, who is asymptomatic at rest, but normal routine activity, less than normal routine activity precipitates symptoms. So it's a patient having moderate symptoms, who is comfortable at rest, but less than normal routine activity precipitates symptoms. What is class 4?
Patient has a
Patient is either bedbound and or have symptoms.
No, define once more. Tell me.
Patient is symptomatic at rest, and the symptoms are refractory to the treatments.
Symptoms are
refractory to the treatments.
No, need not be refractory. Plus, class 4 is a patient who is severely symptomatic.
Yes.
Who can be symptomatic even at rest, or cannot perform any duty without developing symptoms. So it should be you should be thorough with all these class 1, class 2, class 3, class 4. So class 1 is a patient who has got a heart disease, who is asymptomatic on normal routine activities. You may also add that unaccustomed exercise may or may not precipitate symptoms. And the symptoms considered are palpitation, breathlessness, cardiac pain, or fatigue. Any one is enough. Class 2 is a patient who has got a heart disease, who is having mild symptoms. Less than normal routine activity precipitates symptoms. Class 3 is a patient who has got moderate symptoms. Less than normal routine activity precipitates symptoms. Class 4 is a patient who has got severe symptoms, who can be symptomatic even at rest, but he cannot perform any duty without developing symptoms. So you must be clear about all these definitions of class 1, class 2, class 3, class 4 symptoms. Okay, so this patient had class 3 symptoms. Okay, go ahead.
So 1 second.
He was advised.
He was advised wall repair surgery, which he underwent in 2000. After the surgery, he was advised to discontinue the regular penicillin injections.
What does that mean? What does that mean?
So the possibility probably prolapse.
Yes, sir. Mostly it's a mitral prolapse, sir, rather than the rheumatic etiology.
Surgeon might have thought that it is not rheumatic etiology, but it may be some other etiology, and so there is no need of continuing
penicillin injections.
Penicillin prophylaxis. Very good. Okay, go ahead.
He does not know why the penicillin was stopped. He had a temporary improvement for the 2 years. He started developing symptoms again. On consulting the surgeon, he was told that the surgery was not successful and he must undergo the radiosurgery, most likely wall replacement.
Okay.
However,
go ahead. Yes.
However, he continued on the medical management and had satisfactory improvement. 6 years ago, he deteriorated again and was planned for the radiosurgery. However, the previous day of surgery, the surgeon postponed the procedures and asked him to continue the medical management. He was told that surgery carries a high risk. He was detected to have the high blood pressure and was given drugs for that, and his BP was brought down to the normal. With this, he became much better and remained in NIHA class 2 most of the time, with occasional deterioration till the 1 week ago, when he started deteriorating and had episodes of PND 5 days ago.
What is the effect of systemic hypertension on mitral regurgitation?
It increases mitral regurgitation, sir.
What is the effect of systemic hypertension on aortic regurgitation?
Aortic it decreases, sir. Yeah, sorry, it increases, sir. Aortic regurgitation due to the increase in
both the lesions will increase, and
yes,
the only difference is that the mitral regurgitation is dependent upon which pressure.
In left ventricular in diastolic patient.
Mitral regurgitation is when a patient is having systemic hypertension. Mitral regurgitation is dependent upon what pressure? Is it dependent on the LV diastolic pressure or aortic systolic pressure or aortic diastolic pressure? Which pressure decides the mitral regurgitation in a patient with hypertension?
Aortic systolic
yes.
Systolic pressure. Aortic systolic pressure.
Aortic systolic pressure. The aortic systolic pressure decides the regurgitation because when the aortic systolic pressure goes up, the gradient between the left ventricle and the left atrium during systole goes up, and that will result in more severe or more significant mitral regurgitation. What pressure decides the aortic regurgitation?
So LV and diastolic pressure.
No, LV and diastolic pressure to some extent, but more important is which pressure decides the aortic regurgitation? Is it aortic systolic pressure, aortic diastolic pressure, LV diastolic pressure, left atrial pressure?
LV diastolic pressure.
LV diastolic pressure is very marginal, but the most important thing which decides the aortic regurgitation is the aortic diastolic pressure. That's the because the pressure head which drives the aortic regurgitation is the pressure difference between the aortic diastolic pressure and the LV diastolic pressure. So LV aortic diastolic pressure goes up, that will result in more and more of aortic regurgitation. Okay, right? Yes. So one of the reasons why he improved might have been because his blood pressure was brought down, which might have resulted in less of regurgitation, and that might have resulted in improvement of his symptoms. Okay, right? Go ahead.
There was irregular palpitation associated with the paroxysmal nocturnal dyspnea.
What does that mean? And then what does that mean?
Maybe due to the LA enlargement, patient may develop atrial fibrillations.
Yes. So atrial fibrillation is more frequent in which lesion? Aortic valve lesion or mitral valve lesion?
Mitral valve lesion, sir.
Mitral valve lesion. So for the 40 years, sometimes the patient did not develop atrial fibrillation. Does that make you start thinking that it may not be a mitral valve or it may be some other valve involvement? You can keep your mind open. So whenever there is no, because most of the times the long-standing history of a mitral involvement will result in atrial fibrillation because of the large left atrium, and these patients can have mitral regurgitation, atrial fibrillation. So absence of atrial fibrillation makes you start thinking that whether the mitral valve is normal and the pathology, the lesion may be in some other valve. Okay, go ahead.
So there could be a ASD, associated ASD, a small ASD, small to pick up, but decompressing the LA.
Yeah, okay. In a patient with ASD, in the presence of mitral stenosis, the left atrium can be decompressed, and that can result in LS of left atrial enlargement. It's a good point. Okay, very good. But ASD patients can develop atrial fibrillation because they can have dilatation of the right atrium, especially in presence of in the Lewton-Backer syndrome, where the left to right shunt becomes very torrential in a patient with ASD, that can result in a larger right atrium, and these patients can develop atrial fibrillation secondary to right atrial dilatation. So there is a possibility, but I'm just discussing in general. Whenever there is an absence of atrial fibrillation or a long period of symptom, I think you should start thinking that mitral valve may not be the culprit. In order to think, it's only the thought process by listening to the story. Okay, right, go ahead.
He has a pedal edema for the past 7 days, which was come down with increasing urination after hospitalization. So no step syncope, hemoptysis, cyanosis, cardiac pain, or right hypochondrial pain. He was taking one drug which makes him pass urine, another drug which is to be taken 5 days a week, and 2 other drugs meant to control the blood pressure to improve the heart function. He has been very meticulous about his medications.
Okay, right. Okay, we'll go through the rest of the story also, and then you discuss the story part. Past history.
Past history of migrated polyarthralgia involving major joints at the age of 7 and 10. He was given Ayurvedic treatment and got relief. No history of heart disease at birth. No history of the diabetes mellitus.
Okay.
Family is
all right. Yes.
Mother is hypertensive. Personal history not significant.
Okay. So is the story past history enough for you to diagnose rheumatic fever, polyarthralgia?
Yes, sir. According to it was involved the major joints, polyarthralgia. So age 7 and 10 would, so we can say it could be a rheumatic etiology.
Modify Jones criteria, accept polyarthralgia as a major sign, major criteria. What is the
yes, sir, in high prevalence area,
yes, high prevalence area, it's a major criteria, sir.
Yes. In a high prevalent area, the polyarthralgia can be considered as a
major criteria.
So, do you know what is the the present recommendation, modified Jones criteria recommendation?
Yes, sir.
Yes, what is it?
Sir, actually, they classified into the low prevalence and the high prevalence, sir.
Okay.
In a low prevalence, it should be less than 2 in school children's, less than 2 per 1 lakh. And in adults, sir, it's 1 per 1,000, sir.
Okay, very good.
Okay. In high prevalence, it's more than 2 per 1 lakh in case of school children, and for the adults it's more than 1 per 1,000, sir. Sir, in a major criteria, in high prevalence, sir, there is carditis plus subvolulitis, sir. Then there is migratory polyarthritis. Migratory polyarthritis. Then there is Sydenham chorea, major criteria. Then subcutaneous nodules.
And
So in
Erythema marginata.
erythema marginata.
also.
Yes, sir.
In the high prevalence countries,
Is this the high in high prevalence countries, sir? There is carditis, subvolulitis, monoarthritis, monoarthritis,
polyarthritis or even monoarthritis.
migrated polyarthralgia. Then yes, Sydenham chorea. Then erythema marginatum.
Not.
And subcutaneous.
Yes, subcutaneous. Sir, in case of
so this is the criteria, the diagnostic criteria for rheumatic fever modified 2015. Low risk population, carditis, clinical or subclinical, arthritis, only polyarthritis, chorea, erythema marginatum, and subcutaneous nodules. High risk population, carditis, clinical or subclinical, arthritis, monoarthritis or polyarthritis. That is one difference. Then presence of polyarthralgia also is a major criteria. Then chorea, erythema marginatum, and subcutaneous nodules. Minor criteria, low risk population, polyarthralgia is a minor criteria, while in high risk population, polyarthralgia is a major criteria. In high risk population, equivalent to polyarthralgia, the minor criteria is monoarthralgia. Hyperpyrexia, those are minor differences, 38.5 degrees and hyperpyrexia more than 38 degrees centigrade. Minor difference. ESR more than 60 and in high risk population is more than 30 and CRP the same and prolonged PR interval. So there are few differences between the high risk population and low risk population for the major criteria as well as minor criteria. Okay, so in here India can be considered as a high risk population. So the polyarthralgia, migratory polyarthralgia involving major joints make us start thinking. He had 2 episodes. Make us start thinking that he might have had acute rheumatic fever. Okay, right. Yes. So discuss the case, Egnath.
It's a 53 years old male patient, sir. History of exertional palpitations.
Now you draw conclusions. What may be the etiology in this case?
Sir, as a past history suggests of migratory polyarthralgia, that is major. So it definitely is a rheumatic etiology.
Yeah, so most likely it is rheumatic etiology.
Rheumatic etiology. And patient presented.
What is the hemodynamics of the lesion? Is it a regurgitation lesion, or is it it is a volume overload or a pressure overload or a myocardial disease? What is the hemodynamics of the cardiac pathology?
Sir, as a patient given the symptoms that exertional palpitation and palpitations, and so it is the volume overload condition, sir.
So it's volume overload condition.
Yes, sir.
So of the volume overload conditions, you will consider which one as the most likely.
So mitral regurgitation.
Okay, very good.
Yes.
And he has undergone a valve repair. And the valve repair was it satisfactory or not satisfactory?
It is not a satisfactory, sir.
Not satisfactory because the patient became symptomatic again. And then what else? So possibility that he might have had the regurgitation has become more severe, and yes, he might have developed some degree of LV dysfunction, as evidenced by the surgeon's warning that he is a high-risk candidate, and so redo surgery is not possible. Patient is presented with paroxysmal nocturnal dyspnea, edema of the pedal edema. All this indicate that patient has developed a right heart as well as left heart as well as right heart failure, and also the surgeon's caution about high risk indicates that patient has developed a significant degree of LV dysfunction. Okay, okay, right. So That is from the story. That is the conclusion that you can draw. Do you think that this could be, somebody has suggested that this could be a bicuspid aortic valve? Who suggested that bicuspid aortic valve? Can you tell me the person who thought that it could be bicuspid aortic valve? Please tell me your thought process and why did you start thinking that it could be bicuspid aortic valve? Whenever you draw a conclusion, you should have a reasoning. Or do you think that this could be a tri-leaflet congenital valve abnormality? Because the bi-leaflet valve very often gives rise to stenosis and regurgitation, while if it is tri-leaflet, it can give rise to significant regurgitation. So do you think that this could be a congenital valve abnormality, aortic valve abnormality, and that has resulted in significant aortic regurgitation? Usually for significant aortic regurgitation, very often the repair is not very effective. So the repair, the valve was repaired is a strong point in favor. I would strongly go for mitral valve repair because mitral valve is more frequently repaired, more efficient, and the patient can have a perfectly normal life. And what are the advantages of Agnath, what are the advantages of repair or replacement?
Sir, first thing is, sir, patient, get rid of the anticoagulants.
There is no need of anticoagulation. Provide the patient in?
Not in sinus rhythm, sir.
Okay, the patient is in normal sinus rhythm. Then
Yes.
the repair is the patient after the valve repair need not be on oral anticoagulation. Okay, right? Yes. 2. In mitral valve repair, subvalvular apparatus is completely retained. What is the advantage of subvalvular apparatus retainment?
Sir, if surgery needed, sir, we can.
It's not the future surgery that matters. If the papillary muscles are retained, that can result in maintaining the shape of the ventricle. So you see, what is the normal shape of the ventricle? What is the normal shape of the ventricle? Any one of you? What is the normal shape of the left ventricle? It is something like a bullet. So, or you can say that if you have seen a rugby ball, the LV is something like a rugby ball with one portion of the pointed portion is cut off, and that becomes flat.
Elliptical, sir?
Elliptical also is right. Elliptical shape. It is elliptical. And what is the shape which is most indicate dysfunction of the LV?
Globular, circular.
Globular. It becomes globular. And just like so the best example is that when the left ventricle changes its shape from rugby ball to football, and it indicates that the patient has developed a significant LV dysfunction. A globular shape is bad. So when a patient's the papillary muscles and the chordae plays a major role in maintaining the size and morphology of the left ventricle. So in a patient who undergoes mitral valve repair, the mitral valve apparatus is well retained, and that will result in maintaining the shape of the ventricle to its normal pattern. While when if the papillary muscles are removed, that can result in ventricle losing the shape, becoming globular, and that is why always posterior papillary muscle is retained, and that helps to maintain the shape of the ventricle. So my mitral valve repair has got great advantages. Another is in the expert hands, the mortality of mitral valve repair is less, and prognosis is much better. So wherever, but it needs expertise. That is the one problem. Mitral repair needs expertise. So mitral repair is definitely superior to mitral replacement, provided the valve is repairable, the papillary muscles and subvalvular apparatus is maintained. That helps to maintain the shape of the ventricle, and long-term prognosis also is better, and the patient need not be on oral anticoagulation. There are many advantages. So mitral valve repair definitely is the treatment of choice, surgery of choice in a patient with mitral regurgitation wherever it is possible. Okay, right? Yes, go ahead. So he has developed a, so most likely the surgery was not successful. There is certain recurrence of mitral regurgitation, and the surgeon said that you have to undergo a redo surgery. And surgeon also said that the risk is very high. So what does that mean? Eknath? Most likely patient has
LV dysfunction. LV dysfunction.
Significant LV dysfunction. Okay, okay. So the conclusions that we can draw are most likely the patient has got a volume overload, a regurgital lesion, most likely mitral valve, which got repaired, but the repair was not successful. The patient became symptomatic again, most likely because of the recurrence of the symptoms, recurrence of the lesion, or the residual lesion becoming more and more progressively becoming more and more severe. The patient also started developing LV dysfunction and also had episodes of paroxysmal obstructive dyspnea, or at least one episode of paroxysmal obstructive dyspnea indicating left heart failure, and also had some edema, the pedal edema indicating biventricular failure. Okay. And regarding the etiology, in view of the symptom of polyarthralgia twice in his childhood, most likely the etiology of the valvular lesion must be rheumatic. Okay. Any other thought process? Only thought process that we were discussing is that somebody had said that there is a bicuspid aortic valve or a aortic valve abnormality congenital, and that may be the reason. And if he can come out with this argument, then we will accept it. What is your argument for you to consider that this could be an aortic valve pathology? Okay, now we'll go to physical findings. Okay, this is over. Okay, right? Yes. Eknath?
Yes, on examination, patient is well built, no syndromic feature, no dyspneic, not dyspneic, no cyanosis, clubbing, not anemic, mild pedal edema present.
Okay.
On CVS examination.
CVS examination, you can always categorize into two: extra precordial examination, which is JVP, pulse and blood pressure, and then you can subsequently you can give a precordial examination, which includes inspection, palpation, percussion, and auscultation. So that will becomes a description. Everything becomes more systematic and more clear. Okay, right? Yes.
On CVS extra precordial examination, JVP not elevated above the sternal angle, normal wave pattern, pulse is 70 per minute, regular, high volume, collapsing.
What do you mean by normal wave pattern?
Sir, A and V wave, they are variable with normal with the respiration.
Okay. And what happened in a JVP? What can happen with breathing?
During breathing, sir, during inspiration, JVP increases, sir.
Why?
Because of increased volume in right atrium that lead to increased JVP.
Anybody else? What is your thought process about what is the JVP behavior in a normal person when he takes a breath in?
So JVP rises because due to the increase in the pull in the intrathoracic pressure, the RA is unable to accommodate the extra blood that is running in because of the decrease in the intrathoracic pressure. So that is indicated as a rise in JVP.
Anybody else who would like to give any comment? What happens to jugular venous pressure in a normal person when he takes a deep breath in? He said, will it rise? Will it remain normal, or will it drop?
JVP reduces, the height reduces, but the waveform pattern becomes better.
What did you say, JVP?
So height of JVP reduces in inspiration, but the waveform pattern becomes better.
Wave pattern becomes more prominent. What is the explanation? Why should the JVP come down?
Because of the negative intrathoracic pressure.
Very good. It is because of the negative intrathoracic pressure. There is a negative intrathoracic pressure that will result in
Decrease in the JVP
decrease the
during
pressure in all the cardiac chambers, right atrium, right ventricle, because it is after all the intrathoracic pressure also has got an influence on the pericardium and can be transmitted to the cavity also. That will result in, and as somebody has rightly said, the waves become slightly more prominent. The A and VA wave becomes prominent, but the mean right atrial pressure, which is reflected into the jugular veins pressure, will come down. If it does not come down, what does that mean?
The abdominal jugular reflex is positive, sir.
All right.
RV dysfunction is there.
Yeah, RV dysfunction. It is in RV dysfunction that when there is a what mechanism, explain? In RV dysfunction, why should JVP go up?
Due to increase
failing RV cannot able to accommodate the more increased venous retention.
Very good. During inspiration, when there is sucking effect, more volume of blood will come to the right atrium because of the negative intrathoracic pressure. But if the RV is dysfunctional, then it cannot accommodate the extra volume of blood that will result in elevation of the right atrial pressure, and the mean jugular pressures can go up. So normally the mean jugular pressure comes down, the wave pattern can become slightly more prominent, but the mean jugular pressure will be lower during inspiration in a normal person. But if the JVP goes up, that indicative of RV dysfunction. So in every patient, when you examine, you should always give a comment about JVP during inspiration, whether it is going up, whether it is remaining the same, or is coming down. Okay, so it is very important for you to comment about the JVP when normal, when the patient is perfectly normal and breathing normally, and also when the patient takes a deep breath in. Okay, right. Go ahead. Yes.
Pulse 70.
How will you recognize a wave and how will you recognize a V wave?
Sir, A wave is a sharp, sir, means it's a flickering wave, sir.
Yeah, it's a sharp rise, sharp fall.
Sharp
Okay,
fall.
very good.
And V wave is a well sustained wave.
Eh?
V wave is well sustained, sir.
What do you mean by well sustained? What is the difference between A wave and V wave?
So A wave is just before the carotid pulsation, and the V wave is after the carotid pulsation.
Okay, that's why timing. The A wave is before the carotid pulsation, and V wave is after the carotid pulsation. So you can time it with the carotid pulse and recognize A wave and V wave. But in the description of the pattern of the wave, A wave is a sharp rise and a sharp fall, and V wave is a
expansile wave.
Yeah, it's expansive wave, but it's the pattern. When it's expansive, it is a slow rise and a
slow rise, slow fall.
Slow fall.
No. Slow rise and a sharp fall. When it is a slow fall, what are the conditions in which you can get a slow fall?
Tricuspid stenosis,
that's the most important you should think of. Then
pulmonary arterial hypertension, RV failure.
Not RV failure, RV dysfunction. Where when there is a compliance failure of the RV, the Y descent can be slightly slower. But when it is when the Y descent is slower, you must always think of the possibility of tricuspid stenosis. So A wave, sharp rise, sharp fall. B wave, slow rise and sharp fall. And timing, the A wave is pre-carotid pulse and B wave is after the carotid pulse. Okay, right? Yes. Have you heard of H wave? Have you heard of H wave? In jugular venous pressure, have you heard of H wave? Anyone of you? H wave is a positive wave that can be seen in patients with late diastole, in patients with bradycardia. What happens? What can be the mechanism for H wave? When there is bradycardia, what happens? Which phase lengthens during this diastolic phase or systolic phase? In the bradycardia, which phase of the cardiac cycle becomes longer? He said this is
Diastole.
Diastolic.
It's a diastole.
Diastolic phase becomes more and more. And when the diastolic phase becomes more and more, and the venous return is regularly occurring into the right atrium, or a late phase of the diastole, there can be an additional positive wave. So not a very prominent wave. This is known as the H wave. It was described by a German. Its name starts with H. That is how the wave was given and named H wave. Some of the examiners may ask you what is an H wave. So H wave is a late positive wave that can occur in the jugular venous pressure tracing, and is usually it's seen only in patients with a very slow heart rate, especially in the late phase of the diastole. Okay, right. Go ahead.
So pulse 75 per minute, regular, high volume, collapsing. No thickened vessel wall, all peripheral pulses filled, no radial or the radiofemoral delay.
Okay.
So,
blood, from the pulse, what is your conclusion?
Pulse mostly says looking regurgitated lesions, and it mostly the aortic walls.
Yeah, so you suggest you an aortic regurgitation because of the high volume collapsing pulse. Okay, right, yes. Of the peripheral signs of aortic regurgitation, what is the most important peripheral sign which definitely indicate that is regurgitation? Collapsing pulse can occur in many conditions. It can occur in anemia, thyrotoxicosis, beriberi, all those conditions. But
Duragis sign, sir. Duragis sign, sir.
The Durosis sign is Durosis, especially the diastolic component of the murmur, is audible only in severe aortic regurgitation. Okay, very good. Yes. Go ahead.
Sir, and blood pressure, right upperly 170/40. Then right lower limb 220 systolic blood pressure.
What does that mean?
Sir, there is a pulse pressure of 50, sir. I'm sorry, the difference. Sorry. The difference between upper and lower limb pressure is 50, sir. So Hill's sign is positive.
Okay. How will you? What is the interpretation of Hill's sign? Hill's phenomenon. Hill's sign. How do you? What is the significance? At what level it is significant? Can you grade the Hill sign?
Sir, difference less than 20 to 40. Less than 20 is mild. 20 to 40 is a moderate. 40 to 60 is a severe.
Anybody would like to correct it, or others agree to it?
So 20 to 40, 40 to 60, and more than 60 is mild, moderate, severe. But according to the recent their guidelines or literature rather, it might not be very significant, the Hill sign, but just for the historical perspective, I will mention it in the case.
Yeah. I agree with you that now there is a thought process that this Hill sign may not be very significant, but if you're asked a question, the answer is that up to 10 is normal. The difference in systolic pressure between the upper and lower limbs up to 10 is normal. 10 to 20 is borderline, or not borderline, equivocal. 20 to 40 is indicate mild aortic regurgitation. 40 to 60 indicates moderate, and above 60 indicates severe aortic regurgitation. As somebody has rightly pointed out, there is a thought process that the Hill sign may not be very significant. What is the other interpretation? This patient is having what else?
Sir, very wide pulse pressure. Again, the pulse pressure representations are 40 to 60 is mild AR, 60 to 80 is moderate AR, and 80 to 100 or more than 100 can be severe AR.
In aortic regurgitation, which pressure is most important? Is it a systolic pressure, diastolic pressure, or a pulse pressure?
Pulse pressure.
Which pressure is most important? What is the pressure which is affected by aortic regurgitation?
Diastolic pressure.
Diastolic pressure. Diastolic pressure is the one which is affected by aortic regurgitation. The systolic pressure may remain the same, and because of the lower diastolic pressure, they will have a wide pulse pressure. Actually, the diastolic pressure is the one which will tell you about the severity of aortic regurgitation. So if the diastolic pressure is less than 40, that usually indicates severe form of aortic regurgitation. Maybe even sometimes it may be as low as 20, and sometimes you may hear some Corrico sounds even up to 0. So aortic regurgitation, the aortic diastolic pressure is more important than aortic regurgitation. Okay. 170, what does that mean? Here the upper limb pressure is 170 systolic. What does that mean?
Systolic pressure is high, means high volume is due to regurgitation. LV and diastolic volume is more, and so during the systolic, more volume is ejected into the aorta, and that lead to the.
Does the systolic pressure goes up in a does the systolic pressure go up in a patient of aortic regurgitation? No, does not. Usually the diastolic pressure is very low and the patient will have a very high pulse pressure. And systolic pressure, if it goes above 140, you should consider hypertension. And you have to treat for hypertension. Because you can in aortic regurgitation, the pressure which is affected is diastolic pressure. And because of the lower diastolic pressure, these patients can have a high pulse pressure. But systolic pressure cannot go up. If the systolic pressure goes above 140, then you should consider that the patient is having systemic hypertension. And there is an indication to bring down the blood pressure below 140. The patient's aortic regurgitation can actually improve. So in this patient, the pressure above 140, 170 may indicate that the patient is having some degree of systemic hypertension. Also, his lower limb pulsation pressure is 120 millimeters of mercury. Why this patient who is having collapsing pulse and all those things having a diastolic blood pressure of 40? In aortic regurgitation, what is the situation where the
sir, actually, sir, patient might be could be in failure, sir.
Very good.
Increase left
LV
end
diastolic
diastolic
pressure is higher, sir.
yes.
Not only the diastolic pressure, when the patient is in heart failure, the one of the mechanisms that happens in a heart failure patient is the peripheral vasoconstriction. So some of the vasodilatation, which is secondary to aortic regurgitation, is actually is wiped out, and the patient can develop some degree of peripheral vasoconstriction, and the diastolic blood pressure can gradually creep up. So in a patient with heart failure, all the peripheral signs of aortic regurgitation may not be florid, and sometimes the diastolic pressure can gradually can get the diastolic pressure can go up also. That can happen. So it's in this patient, 170 may indicate that the patient may be having systemic hypertension, and 40 may indicate that probably the patient has started developing some degree of LV dysfunction or heart failure. Okay, right, go ahead.
So serious precordial examination, inspection and palpation. Apex beat is 6 left intercostal space, 1 centimeter outside, and it's a forceful. No thrill.
Outside the anterior axial line, it is 1 centimeter outside the
anterior axillary,
indicating that the heart is it's really huge.
Hugely. It's a
very huge heart. What is the normal positioning of the apex beat?
Sir, in 5th intercostal space, middle half inch medial to the midclavicular line.
Okay, 1 centimeter medial to midclavicular line. Here it is in the 6th intercostal space, outside the 1 centimeter outside the anterior axial line. So it's significantly enlarged. Okay, right. Yes, go ahead.
It's a forceful in nature. No thrill or the sound palpable at apex. No parasternal lift. No sound or thrill felt in base of the heart. Pulsations are felt in the suprasternal notch. Abdominal aortic pulsations are felt in the epigastrium.
Okay. How do you differentiate the abdominal aortic pulsations from the RV pulsations at the epigastrium?
Sir, RV
by keeping the thumb over the epigastrium, sir, facing towards the left shoulder. If you feel the pulsation from the pulp of the tip, means it is RV pulsation, sir. If it is in the pulse felt in the pulp is that is aortic pulsation, sir.
Okay, very good. What else? What else can you do?
Liver pulsation, if it is towards left side, the pulsation felt means it is liver pulsation.
Okay, towards the right side. Okay.
Right.
Okay. Anything else can you do? If you ask the patient to take an abdominal inspiration, what can happen?
The delay in the
If you ask the patient to take a good breath in what can happen to these pulsations?
Pulsation will be delayed, sir.
Huh?
RV pulsation will become easily variable. Aortic pulsation may become slightly reduced.
Yes, the RV pulsation will become more prominent because the RV comes down and the pulsations will be better felt in the abdomen, in the epigastrium. While when the abdominal breathing, as the anterior wall of the anterior abdominal wall moves out, the distance between the aorta and the anterior abdominal wall increases, and that will result in less pulsations of the abdominal aorta. So during inspiration, the RV pulsation becomes more prominent, while abdominal aortic pulsation becomes less prominent. So there are 2 points. One, as you rightly said, the pulsations which are felt at the tip of the finger indicate RV pulsations. Pulsations which are felt at the pulp of the finger indicate abdominal aortic pulsations. On inspiration, the RV pulsations can become more prominent, while the abdominal aortic pulsation becomes less prominent. Okay, right. Go ahead.
Sorry, sir.
Percussion.
Yes, sir. On percussion, dullness corresponds to the
Apex beat.
apex beat. Second and third, right intercostal space close to the sternum is dull up to 3 centimeters from the sternal border. Right border dullness of the heart does not extend beyond the right sternal border.
What does that mean?
Sir, actually, second, third, right intercostal space close to sternum is dull up to 3 centimeters from sternum. Maybe it could be due to root dilatation or something. Yes, sir.
Okay, the aorta may be large. Okay, right. Yes.
Aorta, yes, yes.
There's a possibility that aorta may be large. He has got systemic hypertension. There are many reasons for this aorta, and also he has got aortic regurgitation. So most likely, this aorta may be large. Okay, right. Yes. Right border dullness of the heart does not extend beyond the right sternal border. What does that mean?
So the right atrium is normal in
Yes, right atrial not enlarged, sir.
Right atrium is not enlarged, so unlikely that patient is having any tricuspid valve disease because right atrium is not enlarged. Okay, right. Go ahead. Right, yes. Okay.
Yes, sir, that's
Auscultation.
incidence. Sir, on auscultation.
Any other point you want to discuss? Or somebody was raising a point? No? Okay, right. Okay. Right. Auscultation.
On auscultation, sounds first. This one is feeble. Best audible at mitral area.
What are the conditions you can get feeble S1?
So calcified mitral. Calcified. Yes. Severe mitral stenosis, we also get a feeble.
No, don't go for severe mitral stenosis feeble. You said that calcification of the valve can make it, the sound can become feeble. Okay. So many times, even when there is calcified valve in mitral stenosis, still you can get sometimes loud sound. But you can separately say that calcified valve may be associated with feeble S1. Okay, right. 2.
So AR, MR.
Okay, MR patients also can be, the S1 can be masked and the sound can become feeble. Okay, 3.
So bradycardia.
Bradycardia, why should the S1 be feeble? You can explain it, you explain it. I agree with you, it's possible.
Prolonged LV diastolic time, sir, that will fill the LV, and when closing, it is closing from a less. The distance is really close. The leaflets are close, so they don't make much sound when closing.
That can happen, but usually it is not the thing because what is the last phase of a cardiac diastole?
Sir, atrial contraction.
Yeah, it's atrial contraction. So atrial contraction will wide open the mitral valve, and when it floats back, the LV can contract. So even in bradycardia, very often this one is normal. It depends upon the atrial contraction. So what can the thing which can make this one feeble?
Sir, obesity or emphysematous chest can also.
Yes. Transmission. Most important thing you should mention is a prolonged PR interval. When the PR interval is prolonged, S1 can be feeble. Why? in prolonged PR interval, why S1 becomes feeble? Any one of you? Beg your pardon?
Sir, due to delay
When does the ventricle contract in relation to the atrial contraction? You might have done echocardiogram. You can see that the atrial contraction fills the LV, and the LV starts contracting as soon as the atrial contraction is over and the atrium starts relaxing. So the ventricle contracts at a time when the valves are fully open, and the valves are floated back when the LV contracts, giving rise to S1. In a patient, loud S1 or normal S1. In a patient with prolonged PR interval, what happens? After the atrial contraction is over, atrium starts relaxing. When the atrium starts relaxing, what happens to left atrial pressure?
Actually, left atrial.
There is prolonged opening of the mitral walls.
No, once it starts
When the patient is having prolonged PR interval, what will happen to the mitral valve?
So will be less
Let
close to the
let close.
distance of left atrial decrease.
When after the atrial contraction, what happens to atrium?
the atria relaxes,
Relaxes. Then what happens to atrial pressure?
it falls.
When atrial pressure falls, what will happen to the mitral valve?
So it will close due to the gradient, increasing gradient.
A decrease in gradient. Rather, no gradient or even left atrial pressure transiently can be even less than that of the LV pressure, and the mitral valve starts floating back. And then when the ventricular contraction occurs, when the mitral valve has started floating back, that can give rise to a feeble S1. So one very important reason for feeble S1 is prolonged PR interval. And another reason for feeble S1 is LV dysfunction. Patients with systolic dysfunction, LV systolic dysfunction, can have a feeble S1. Another reason for feeble S1 is aortic regurgitation. Patients with aortic regurgitation can have a feeble S1. Mechanism?
Sorry, there is early closure of the mitral valve due to the increase in diastolic volume.
Yes, because not only in the diastolic pressure, the jet from the aortic regurgitation can strike the anterior mitral leaflet and makes it partially closed, and that can result in less range of movement of the mitral valve, resulting in a feeble S1. So there are a number of conditions where there can be a feeble S1. So we have to explain here what is the mechanism after we have heard about the various murmurs that this patient is having. Okay, right, go ahead.
Sir, murmurs, pants study blowing.
No, we are not. We are just stopped at S1 feeble. You have to read the rest of the things.
Sorry. S1 is feeble, best audible in mitral area. S2 is audible at the best audible at the pulmonary area. Normal in intensity, normal split, no S3, S4, constant ejection click at the second and third right intercostal space.
Interpretation.
Sir, ejection click in right second and third intercostal space, it may due to the aortic root dilatation.
Yes, so it may be an aortic click. Okay, right, yes. What do you mean by constant ejection click?
It's not variable with the respirations.
And what is the situation where it can vary?
Valvular click vary with the valvular clicks.
Valvular PS, yes. When there is a patient is having valvular PS, it can be associated with a basic ejection click. Okay, right. What is the pattern of second heart sound in a patient with aortic regurgitation? Here we are suspecting aortic regurgitation because of the collapsing nature of the pulse.
Sir, second heart sound, sir, as a large volume of LV is ejected, so there is prolonged opening of the aortic wall. Aortic wall opens closes later, means there is close speed we could expect, sir.
Close speed is the one which happens in a patient with aortic regurgitation, but your explanation is not correct. In aortic regurgitation, I agree with you that there is a high volume, but because of the low peripheral resistance, LV will be able to eject the blood without any difficulty. So the ejection is not unduly prolonged because LV is because of the low peripheral resistance. What is the mechanism which results in a delayed close to the aortic valve in aortic regurgitation?
Increased hangout interval.
Yes, it's a prolonged hangout interval. These patients can have prolonged hangout interval that can result in a delayed close to the
Aortic.
aortic valve. So then here why it is normally split?
And maybe due to failure patient. So patient is failure.
Systemic
So
If the patient is in failure, what will happen?
there won't be a hangout interval with it will decrease.
Okay, there can be slight reduction in the hangout interval, but when there is a LV failure, what will happen to the A2? Will it be delayed or it will be early?
It will be early, sir.
Why? When there is LV dysfunction, why should be A2 be early? Actually, LV dysfunction is one of the conditions where there can be paradoxical splitting of the second heart split.
Yes.
That is because the pre-ejection period or the isovolumetric contraction phase is so delayed because of the LV is not able to generate pressure very quickly. That can result in a delayed A2, and sometimes these patients can have paradoxical splitting. So normal split, does that mean there can be an associated some other lesion? Can you think of any other lesion where there can be S2 can be early, A2 can be early? Any valvular lesion? MR. Why associate MR? Why it's early?
Because sir, actually, the volume get distributed, sir. Left ventricle end diastolic volume. So some volume goes into the left atrium, really, and some volume into the aorta, sir. So that's why it closes early.
No, you have to give complete explanation. You are right. So in a patient with mitral regurgitation, LV has got two outlets. One through the mitral valve into leaking mitral valve into left atrium, and other through the normal outlet, which is the aortic valve. So when the LV contracts because of the two outlets, the ejection is completed quickly, and that will result in early closure of the aortic valve. Because the ejection is completed because it has got two outlets, one to the left atrium and other to the aorta, and that will result in early closure of the aortic valve, and hence there can be a wide splitting of the second heart sound. So here the patient with aortic regurgitation has got a normal split, then you should start thinking that whether the patient has got associated mitral regurgitation also.
Yes.
Okay, right. Okay, right. Yes. What does the no third heart sound, no fourth heart sound mean? And what does third heart sound mean in a patient with aortic regurgitation? Presence of third heart sound in a patient with aortic regurgitation, what does it mean? What is your interpretation? What is your interpretation of a third sound in aortic regurgitation?
Severe air.
Severe air. Not correct.
Volume overload, sir?
No.
LV dysfunction.
LV dysfunction. S3 in aortic regurgitation indicates LV dysfunction. That's not another. Of course, LV dysfunction in aortic regurgitation, aortic regurgitation is the only lesion. Obviously means that the patient must be having severe aortic regurgitation.
So can the normal split be because of systemic hypertension, development of systemic hypertension?
Your point is that hangout interval is actually comes down.
Yes, sir.
Well, that can be another explanation that of course what is the thing, when does the aortic valve close, at what pressure?
Sir, once the aortic pressure is less than the LV and diastolic pressure, or the LV pressure.
What did you say?
Sir, once the aortic pressure is less than the LV pressure.
Is that a situation where the aortic valve close? When the aortic pressure is less than the LV pressure, what will happen to the aortic valve?
It will open.
It will open. Aortic valve closes when the aortic pressure,
Diastolic pressure.
LV pressure falls below that of the aortic pressure. I am asking a question: at what level of the aortic pressure does the aortic valve close?
At 7. Diastolic pressure 7.
At what pressure does the aortic valve close?
82, around 80.
Not 82. No, you have to mention whether it is what is the timing of the aortic valve closure in relation to pressure. Is it during systolic pressure, diastolic pressure, or some other pressure?
Diastolic.
Is it during diastolic pressure does the aortic valve close? Any one of you?
After the crossover, pressure flow.
When does the aortic valve close? That's a very simple question.
So diastolic pressure once of aortic wall, aorta crosses over.
What is diastolic pressure? Diastolic pressure is the lowest pressure recorded in the aorta.
Yeah.
So if the aortic valve is closing at diastolic pressure, after the aortic valve closure is the diastolic phase. So what can happen to the pressure? Actually, the aortic valve closes roughly around the mean diastolic pressure, mean aortic pressure. Aortic valve closes around the mean aortic pressure. And at what pressure does the aortic valve open? These two things you should know. Examiners will ask you. At what pressure does the aortic valve open? Yes.
Mean and diastolic pressure.
Mean and diastolic pressure. What do you mean by mean and diastolic pressure? At what pressure does the aortic valve open? It's a very simple question. It's a third year student should know this.
Aortic diastolic pressure.
Aortic diastolic pressure. When the LV pressure exceeds the aortic diastolic pressure, the aortic valve opens. And the aortic valve closes at about the main aortic pressure. So these two things you should know. So I agree with you that when the systemic pressure there is a higher systemic pressure that can result in less of hangout interval, and there can be normal splitting. That also is quite possible. Okay, right. Go ahead. So we'll keep that mind, these things open. And third heart sound in a patient with aortic regurgitation indicate that the patient is having
LV
dysfunction. Very good. Third heart sound in a patient with mitral regurgitation, what does it indicate?
Severe MR.
Severe.
Gives you an idea about the severity of MR, because there is a large volume of blood is flowing across the mitral valve during the early filling phase, and that can be associated with the third heart sound. Third heart sound in presence in a patient with MR does not indicate LV dysfunction. Well, in a patient with aortic regurgitation, third heart sound indicates LV dysfunction. Okay, right. Go ahead. Murmurs.
So, in murmurs, sir, pansystolic blowing, high-pitched murmur, best audible at apex, conducted to the axilla, better audible at the left lateral position, no change with the breathing, grade 3/6. It's MR murmurs. Yes.
Okay.
Then second
can this be VSD murmur?
Unlike
so VSD murmur
external region.
is not conducted to axilla.
VSD, can this be VSD murmur? Can you hear a VSD murmur at the apex?
No, sir. Actually, it's not conducted to axilla also.
Not conducted to axilla. Question is not that. Question is, can you hear a VSD murmur at apex?
Sir, if that's in a small
Yes,
child,
sir, we can.
The entire precordium we can hear the murmur. Sir, in a child, specifically in a child, sir, it's we can hear all over the precordium.
That's right, but there in a
Yes, sir.
Classical VSD is. My question is not that. Can you hear VSD murmur?
Yes, sir. We can hear, sir. We can hear in apex, sir. In case of muscular VSD.
Very good. That's the answer. In a patient with muscular VSD near about the apex, sometimes the VSD murmur is best audible in the apex and is usually associated with the thrill also. But then whenever you get a thrill at the apex associated with the systolic murmur, you should always think of the possibility of apical muscular VST. But as somebody has rightly pointed out, the murmur will not be conducted to the axilla. Right. Okay, yes.
Yes,
Right, yes.
yes. Second is early systolic, blowing high pitch murmur audible at the fourth and fifth left intercostal space, close to the sternum, increase with inspiration, and the passive leg raising, grade 2/6.
This is what.
It's sir, in case of severe aortic regurgitation due to the high volume, due to as the aortic root get dilated, we can get the stenotic murmur, systolic murmur.
Do you think that this is stenotic murmur? Early systolic murmur?
Due to dilatation of the roots. Due to,
can you get an early systolic murmur as an ejection murmur?
Yeah.
Could be due to
Yes, sir. We can get ejection in murmur, sir. Early systolic.
Why? What does the early systolic murmur mean?
Sir, due to the high volume of the blood ejected into the aorta.
No. I'm asking you, what is early systolic murmur? When does the murmur start and when does the murmur end? When you use the term early systolic murmur.
Sir, it starts just after the S1, sir.
No, it starts with this one.
Yes,
not after this one. It starts with this one. And where does it end? What is early systolic murmur? When somebody says that there is an early systolic murmur, what is your understanding?
Before
early systolic murmur means a murmur which starts first sound, but it stops short of the second heart sound. So it starts with first sound and stops short of the second heart sound. Can you get an early systolic murmur if there is an ejection murmur? When does the ejection murmur start? When does the early systolic murmur start? When the murmur starts with first heart sound? So obviously means that as soon as the mitral valve closes, the murmur starts. When does the ejection systolic murmur start?
Ejection is just after S1.
Not just after S1.
Mid-systole.
It starts after the aortic valve is opened. It has to pump, it has to flow across the aortic valve. Then only the murmur can be generated. So there is a small phase between the closure of the mitral valve and opening of the aortic valve. And this phase is known as, what is the phase in the cardiac system? Between
contraction. Isovolumetric contraction.
Isovolumetric contraction phase. So the ejection systolic murmur is never early systolic. Whenever you use the word ejection systolic murmur, you mean three things. One, it is a mid systolic murmur. Two, it is the murmur is because of an ejection of blood from a ventricle to a great vessel. And three, it is a crescendo decrescendo murmur. 3 points are, when you use the word ejection systolic, it means three things. One, it is a mid systolic murmur. Two, it is because of an ejection of blood from a ventricle to a great vessel. And three, it is a crescendo decrescendo murmur. So early systolic murmur is not a ejection murmur.
So this sounds like a tricuspid regurgitation murmur.
Very good. It is a tricuspid. It looks like a tricuspid regurgitation murmur because early systolic blowing high pitched murmur, audible fourth and fifth left intercostal space, close to sternum, increases on inspiration and passive leg raising. So obviously it is a right side
tricuspid. Yes, sir.
Okay, go ahead.
Mid systolic rough, harsh, medium, high pitch, early picking, ejection systolic murmur in a right intercostal space close to the sternum, better audible in sitting up and leaning forward position, with breath held in with expiration, held in expiration, conducted to the both carotid, grade 3/6. The murmur is audible in the left second left intercostal space also. So it is AR.
Yes, Murmur.
AS murmur space due to the high volume ejected into the dilated aorta.
No. Are you thinking that it could be an aortic stenosis murmur, or is it because of a volume of blood coming because of the higher stroke volume?
Sir, higher stroke volume murmur.
Why did you say that?
Sir,
Why did you say higher stroke volume?
So the pulse is normal. In the AS, it will be rising pulse, sir.
No. Looking at the murmur, see, we are discussing the murmur.
So no late peaking is there.
Yeah,
sir,
it's an early peaking murmur. So early peaking is a feature of
Stroke volume.
it's a feature of
high volume.
high volume. Occurs associated with high volume ejection and is not associated with any significant aortic. You cannot say you cannot be certain whether there is a very minimal aortic stenosis, but unlikely to have any significant aortic stenosis. Usually indicates that there is a maybe high volume, and high volume, the higher stroke volume can result in turbulence, and that can give rise to an early peaking ejection systolic murmur on the aortic area. So this can go very well with the possibility of aortic regurgitation because of the higher stroke volume. Okay, right? Yes.
Then early diastolic blowing high pitch murmur best audible at the right second intercostal space, heard down along the left and right sternal border, more on left, better audible in a patient in sitting and leaning forward with breath held in expiration, grade 2 by 6. So it's diastolic murmurs, aortic regurgitation.
Okay, aortic regurgitation. Okay, what are the causes of early diastolic murmur?
So early diastolic we get in pulmonary regurgitation, aortic regurgitation, and in case of truncus arteriosus, that is
truncal regurgitation. Okay, right.
Truncal regurgitation.
And there is one more murmur people have described can be early diastolic.
Sir, the proximal LAD lesion, so dog's murmur.
Sir, that coronary, that I forgot name.
Dog's murmur.
Dog's murmur, yes, sir.
Dog's murmur. Okay, right, yes.
Yes.
So there are, whenever you are thinking of early diastolic, there are three possibilities: aortic regurgitation, hypertensive pulmonary regurgitation, and truncal regurgitation. And of course, by far, the commonest cause of early diastolic murmur is aortic regurgitation. A person known as Doc has described a murmur in relation to a proximal stenosis of the LAD, and it goes by the name Doc's murmur, and people have thought that this also could be a cause for early diastolic murmur. Okay, right? Yes. What is the
can we differentiate this explanation between the valve regurgitation or the root related regurgitation?
Yes, Egnath, what is looking at the murmur? What do you think it is?
Sir, actually, early diastolic murmur in right intercostal space, sir. So, in case of aortic root dilatation due to some connective tissue disorders, we get this diastolic murmur and right intercostal space, sir. In case of valvular lesion,
no, that's not enough. No, that is not enough. Right intercostal space is not enough. You should say that it is audible. It may be audible in the right second intercostal space, but as it comes down, it is more audible on the right side of the sternum.
Yes.
So, in a valvular regurgitation,
we get on left side, sir, left third intercostal space.
Much better audible in the left side. Here, what is your opinion?
Sir, early right intercostal space heard along with left better than the right, sir. So it's valvular, sir.
No. So here it is not very clear. It is well audible on the right side as well as left side, but murmur is louder on the left side than on the right side. So you have to start thinking that it is a more likely to be a valvular regurgitation or to be a combination both. Sometimes a patient with the dilated aorta sometimes can have valvular abnormality also. So a combination can be the cause for aortic regurgitation. Yes, okay, right. Yes. Next one.
Low pitch mid diastolic rumbling murmur audible at apex. This is the Austin Flint murmur, sir.
Why did you say it's Austin Flint murmur? What are the points by which you differentiate Austin Flint from mitral stenosis?
Sir, if there is pre-systolic acceleration is not there, sir, in case of Austin Flint murmur.
Okay.
There is no opening snap, sir.
Okay.
Then in case of mitral stenosis, RV get dilated, sir. In case of
Why should the mitral stenosis RV get dilated?
so severe mitral stenosis, sir, that is due to RV.
Patient can develop pulmonary arterial hypertension and consequently RV can be involved. Okay, right? Yes.
Yes, sir. In case of
what are the points by which you differentiate diastolic rumble in a patient with aortic regurgitation from mitral stenosis? Points 1, 2, 3, 4, 5.
Then, sir, amyl nitrate test. That is one.
No, you don't have amyl nitrate with you when you are doing a clinical examination.
Yes, yes. So first is the opening snap pre-systolic accentuation.
Most important is S1.
Yes, so,
the S1 is loud in a patient with aortic regurgitation. It is mitral stenosis. Because in aortic regurgitation, S1 is either is normal or it could be feeble. Mostly it is feeble. Second point.
Opening snaps.
Pre-systolic accentuation. Pre-systolic accentuation is a feature of mitral stenosis and not
mitral stenosis.
Third point. No, already mentioned opening snap. Opening snap is a feature of mitral stenosis rather than Austin-Flynn murmur. Fourth point.
That RV, sir. RV hypertrophy or dilatation in case of mitral stenosis.
I agree with you, but related to mitral stenosis, you can say that if the patient is if there is a diastolic thrill, that goes more in favor of mitral stenosis. And if the patient is having complications like pulmonary arterial hypertension, atrial fibrillation, that is more in favor of
mitral stenosis.
So these are 5 points by which you differentiate Austin-Flynn murmur from mitral stenosis. They are 1. Loud S1, mitral stenosis. 2. Pre-systolic accentuation, mitral stenosis. 3.
Opening snap.
Opening snap. 4.
4 is
presence of diastolic thrill.
Diastolic thrill.
So, presence of a thrill goes more in favor of mitral stenosis. 5.
Atrial fibrillation.
Complications like atrial fibrillation or pulmonary arterial hypertension. Okay, so these features are more in favor of Austin-Flynn murmur. How will you assess the severity of aortic regurgitation based on oscillatory findings?
Austin-Flynn murmur, that is 1, sir.
Okay, the Austin-Flynn murmur is severe aortic regurgitation. Okay,
severe aortic. Then peripheral signs also, Dorage's sign also.
Right. No, I'm telling you about auscultation.
Long ADM.
Long ADM.
Length of the murmur usually may not be a very good criteria to assess the severity of regurgitant lesions. Because sometimes in patients with mild aortic regurgitation, you can get a long murmur. And in some of the patients with very severe aortic regurgitation, the murmur can be very short also. So the length of the murmur may not definitely tell you about but in general, I can tell you that most of the patients with severe aortic regurgitation will have a murmur roughly at least up to the middle of the diastole. But in general, you should say that for stenotic lesions, length of the murmur will tell you about the severity of stenosis. For example, patients with aortic stenosis, if the murmur is longer, usually indicates severe aortic stenosis. The same is true for mitral stenosis. Longer the murmur, the more severe the stenotic lesion. But that does not apply for mitral regurgitation or aortic regurgitation. The patients with mitral regurgitation, whether it is mild, moderate, or severe, it is a pansystolic murmur. In patients with aortic regurgitation, sometimes even with mild aortic regurgitation, sometimes you can get a prolonged murmur. So the length of the murmur will not definitely tell you about the severity of aortic regurgitation. So how will you assess the severity of aortic regurgitation from auscultation?
S3, sir.
If the S3 is there, yes, it usually indicates that the patient has developed LV dysfunction. But if there is no LV dysfunction, what are the other parameters to assess the severity of aortic regurgitation? One, we have said Austin-Flynn murmur. Anything else?
The radiation of the murmur further below.
Radiation of the murmur?
along the sternal border, parasternal border.
No,
Below.
that will not. No, that will not tell you about the severity. Mr. Systolic murmur, can it help you?
Ejection systolic murmur associated with the
Yes. Early peaking, ejection systolic murmur associated with aortic regurgitation usually indicates severe aortic regurgitation. Any coming to sounds, any comments you want to make about sounds which will help you to diagnose severe aortic regurgitation?
Click, sir.
Eh?
Click.
Any change in the sound which will help you to diagnose the severe or assess severity of aortic regurgitation?
S2.
S2. How does it help you?
It's paradoxical split.
Yes, paradoxical split or a single S2 usually indicates the severe aortic regurgitation. Okay, very good. Okay, so so here, what are the lesions this patient is having?
Sir, this patient having one is austin-flint murmur, second is early mid systolic.
Sir, mitral regurgitation.
Yes, mitral regurgitation.
Diagnosis.
Tricuspid regurgitation.
Tricuspid regurgitation. Yes.
Then there is a flow murmur across the aortic valve,
Aorta.
and the patient is having the murmur of aortic regurgitation.
Yes.
Okay. So, on the basis of the clinical findings, what is your diagnosis?
Sir, on clinical finding, I would like to keep a diagnosis valvular heart disease, severe mitral regurgitation, mostly of rheumatic etiology.
Why did you say severe mitral regurgitation reason?
Sorry, severe aortic regurgitation.
Oh.
Severe aortic regurgitation with
whenever there is a aortic regurgitation as well as mitral regurgitation, how will you assess the severity of which lesion is more severe?
So proximal lesion, sir, that is mitral regurgitation.
No, you cannot use the word proximal lesion is more severe. You can say that when there are two lesions of equal severity, the proximal lesion will manifest more than the distal lesion. That is right. But I am asking a question in presence of mitral regurgitation, aortic regurgitation. How will you assess the severity of these two lesions? Which is more severe? Tell me, if these findings are there, I will consider this patient is having more severe aortic regurgitation. And if these findings are there, I will consider this patient is having more severe mitral regurgitation. What are the findings? Because both the situations, you can have cardiac enlargement. The LV can be, the apex beat can be down and out. Then how will you make out? Or what are the points which will help you to diagnose severe mitral regurgitation?
One is
atrial fibrillation. Atrial fibrillation and pulmonary hypertension.
Okay. If the patient is having complications like atrial fibrillation, that goes more in favor of a significant mitral regurgitation. Okay, right. Yes. Pulmonary hypertension is not usual for pure mitral regurgitation unless they develop severe LV dysfunction. Why? Because in mitral regurgitation, the left atrial pressure, there is no mean elevation of the left atrial pressure. They can have a prominent V wave, and hence there is a V wave is taller, but there is no, unlike in mitral stenosis where there is a mean left atrial pressure elevation, there is no mean left atrial pressure elevation in mitral regurgitation. As the mitral valve opens, the atrium gets decompressed because of the flow of blood into the left ventricle. But if the patient starts developing left ventricular dysfunction, then they can develop mean elevation of the left atrial pressure, and they can develop pulmonary arterial hypertension and complications. So, in a patient with pure mitral regurgitation, normally functioning LV, pulmonary arterial hypertension is not a common phenomenon. But when they start developing LV dysfunction, they can develop pulmonary arterial hypertension. Okay, right? Yes. Atrial fibrillation is a complication which can occur in mitral regurgitation. That, to some extent, tell you about the severity of mitral regurgitation. Yes. What else?
Closed split of S2. S2 split, if it is closed, then MR severity might be severe.
And I could not understand you well. What about the splitting of the second heart sound?
If it is close fit, then it is severe MR.
Oh,
And if it's
wide split and MR.
if it's wide split, it is severe MR. If it is close split or paradoxical split, it is severe AR.
okay, very good. If it is a wide split S2, it usually indicates more severe MR. And if it is close split or a single or a paradoxical, it goes more in favor of severe aortic regurgitation. Very good. Okay, right. Yes. What else?
Peripheral
Yes,
Helps.
you're right.
peripheral signs presence of peripheral signs indicate AR.
Very good. Peripheral signs indicate severe AR. Very good. Yes. What else? You must think what is happening when there's MR, what is happening with AR, and then you should interpret it.
Sir, actually, in this patient, sir, patient is mostly patient has the symptoms
No, I am
of
not
the right
asking
heart.
about. No, I am not asking about this patient alone. I'm asking in general. What are the features by which you say that in a combined lesion, MR is more severe or AR is more severe? I am asking a general question.
Flow murmur across the aortic area.
Very good.
Of
Because the aortic area usually indicates severe AR. Very good. Excellent. Any pulsation that you can look for in MR?
LA pulsation.
Very good. LA pulsations. You can look for LA pulsations. Where do you look for LA pulsations, and how do you differentiate LA pulsation from other pulsations?
LA pulsation we should see in third left parasternal area, sir.
Okay, very good. Third and sometimes fourth, but usually in the third intercostal space, you
Yes.
can get pulsations. And how will you make out whether it's LA pulsations or not?
Sir, actually, if you keep both hands, one at apex and one at the LA pulsation, there is asynchrony with the lifting up hand.
Yes, there is a usually the LA pulsation is slightly delayed compared to the apex beat. Not
Apex.
RV. We are not looking at the RV. There is some asynchrony, or rather the LA pulsations are slightly delayed after the apex peak. So the presence of LA pulsations usually indicate that the patient is having significant mitral regurgitation. So these are the points by which you separate. So the points are: one, the patient is having an S3 and not in heart failure. Usually, mitral regurgitation is significant. Two, if there is a widespread S2, mitral regurgitation is more severe. If the patient is having LA pulsations, that usually indicates the patient is having significant mitral regurgitation. And on the other hand, if the patient is having a prominent peripheral signs, that indicates more severe aortic regurgitation. If the patient is having a close split or a paradoxical second heart sound, usually indicates aortic regurgitation. And if the patient is having a early peaking ejection systolic murmur across the aortic area, that also usually indicates the patient is having significant aortic regurgitation. So these are the points by which you separate out in a combined lesion, whether it is mitral regurgitation is more prominent or an aortic regurgitation is more prominent. Okay, right? Yes. Now we'll have to go to ECG, and of the peripheral signs we have already discussed. Neurosis murmur is the most important peripheral sign, because that usually indicates that there is a reverse flow and the murmur is generated because of the reverse flow. Okay, we will stop at this level. We'll have ECG, X-ray, and echo, and discussion about aortic regurgitation in the next class. Any doubts that you want to ask now, you can ask now. Any doubts you want to clear, you can ask now on the clinical findings. Next class we will go for Eknath. You will continue to discuss ECG,
Yes, sir. Yes, sir.
X-ray,
Good evening, sir.
echo, and also discussion about aortic regurgitation.
Hello, sir.
Yes,
Good
sir.
evening, sir. Hello.
Hello. Any other point you want to? Any doubts you have got? You can clear now.
Sir, can you hear me, sir?
Yes, yes, I can hear you. Your
Sir,
voice
can
is
you-
very low. What is your name?
Bhargav, sir.
Margo, but you speak to the mic because your voice is very low. Okay, right? Yes.
Sir, can you explain how this mid-systolic ejection systolic murmur indicates the severity in AR, sir?
Anybody? Eknath, can you explain to him? Further, I have to ask you a question. What are the mechanisms of production of mid-systolic murmur? There are about 6 mechanisms of production of mid-systolic murmur. Can any one of you tell me? Ejection systolic murmur, mid-systolic ejection can be due to 6 mechanisms.
One is, sir, there is stenotic valve, sir, with normal flow.
Yeah, stenosed valve, normal flow can give rise to ejection systolic murmur.
Yes, sir. Then a normal valve with increased flow.
Okay, there is a normal valve, increased flow, ejection systolic murmur. Okay.
Yes, sir. In case of dilatation of wall, the dilatation of the wall, due to increased dilatation of the root, sir.
Oh, okay. When the ejection of blood is from a normal valve to a dilated chamber, that can give rise to ejection systolic murmur, as can occur aortic aneurysm or a dilated pulmonary artery occur. Yes.
Then normal opening, but structurally abnormal in case of bicuspid valve, sir.
Very good. Yes.
Yes. In case of hyperdynamic circulation, so
hyperdynamic circulation. Yes. 5, 6.
Then 6 sclerosed valves.
Sclerosed. Okay. These are the 6 mechanisms of production of the. So, in a patient with aortic regurgitation, what can be the production? What is the mechanism of production of mid-systolic murmur or ejection systolic murmur?
Dilatation of the due to turbulence.
Okay, dilatation maybe, but it could be also because of the higher stroke volume, large volume of blood is flowing across the normal valve, large volume of blood. So the increase in the stroke volume in a patient with aortic regurgitation usually means that the stroke volume is increased because of the regurgitation. So increase in stroke volume indicates more regurgitation, and that has resulted in a ejection systolic murmur. Is it clear to you, Bhargav?
Yes, sir. Thank you, sir.
Okay, yes. Any other doubt?
Sir,
okay, right. Yes.
Paradoxical split S2 is more for severity of aortic stenosis, or is it also for aortic regurgitation?
It occurs in both. Mechanisms are different. In a patient with aortic stenosis, it's because of the prolonged ejection time. Because of the slow ejection, it takes longer time for the ejection that can give rise to paradoxical splitting. But in a patient with aortic regurgitation, the paradoxical splitting is mostly related to a longer hangout interval of the aortic valve because of the low peripheral resistance. What is your name? Eh? I can't hear you. Okay, does not matter. The different mechanisms are different. In aortic stenosis, it is because of the prolonged ejection time that can result in a delayed course of the aortic valve. In a patient with aortic regurgitation, it is because of the longer hangout interval of the aortic valve because of the lower peripheral resistance. Both conditions can give rise to paradoxical splitting, but the mechanisms of production of the delayed A2 is different. Is it clear to you?
Yes, sir.
Okay, yes. Any other doubts? Okay, right, good.
So
I think
single A2 in this severe aortic regurgitation, single, S2 becomes single at all, and then later it becomes paradoxically split.
Yeah, that can happen that way, it can become single and then subsequently can become paradoxical. And sometimes one problem is that if the valve is structurally damaged, sometimes the A2 can be very feeble also. That's another problem. Because in a patient with rheumatic aortic regurgitation, sometimes the valve may be structurally abnormal and the second heart sound can be quite feeble. And sometimes when the early diastolic murmur starts with the closure of the aortic valve, you may be able, the closure sounds may be partly masked by the murmur. So there are many things, but when you are asked a question, what happens to the second heart sound in a patient with aortic regurgitation? It can be single or it can be paradoxically split. Or if it is a mild aortic regurgitation, it can be normal.
Good evening, sir. Sir, in this patient, the AR is secondary to the valvar lesion, or it can be due to the dilatation of the aortic, the LV itself, and that will cause a root dilatation.
Eknath, what is your opinion?
Sir, AR, it could, sir, AR, it could be, so the lesion is on left side, sir. So I think it could be along with the miss MR, sir, miss simultaneously involvement of the valvular, not due to aortic root dilatation.
Yeah, we can't be 100% certain because the murmur is better audible on the left side, and that, as Agnes rightly pointed out, indicate that valve pathology is the one which is giving rise to aortic regurgitation. But at the same time, it is heard on the right side also. So, but of the two, I also agree with Agnes that I would go for a valvular pathology than a purely the vascular pathology. It was audible on the right side and was better audible on the right side, then I would have definitely gone for a vascular pathology. Here it is better audible on the left side. So on the clinical basis, I would say that most likely it is a valvular pathology rather than a vascular pathology.
Sir, this pansystolic murmur not changing with breathing, does it indicate LV dysfunction or something? The pansystolic murmur no change with breathing.
Not increasing with breathing. Pansystolic murmur not increasing with breathing. Yeah, that does not indicate LV dysfunction. No. That's not nothing. Breathing has nothing to do with LV dysfunction. Of course, RV, there can be that when there is a severe RV dysfunction, the change in intensity of the murmur with breathing, of course, the inspiratory increase disappears because RV cannot because of the RV dysfunction, no more volume of blood can come to the RV. Extra volume cannot come to the RV during inspiration, and hence the murmur cannot increase in intensity. That can happen on the right side, but usually on the left side, the change with breathing is not very significant, and the RV LV dysfunction cannot be diagnosed based on change with breathing. Okay, we'll stop at this level. Next week we will have a discussion on ECG, X-ray, echo, and diagnosis, and a discussion about aortic regurgitation and its management. Okay, right. Good night.
Okay.
Good night.
Okay. Thank you, sir.
Thank you.
Thank you, sir.
Now we will continue with the discussion. Others can also take part. Since we have already started, we will continue with the discussion. So you come
Okay,
prepared. You read about aortic regurgitation.
Yes, sir.
Thank you, sir.
Thank you so much.
Right. Okay, the Imagica group, are you there?
Yes, I am here.
Okay. I think you can stop recording, and I think we have closed the session. You can close
Yes.
it.
Yes. Thank you very much, sir. So from here, I'm ending this meeting. Thank you very much for valuable time.
Thank
Night.
you.
Bye. Good night.
Good night.